We're going to now move forward to our next presentation, Investigating Severe Hepatitis in Children with Dr. David Sugerman from CDC. Dr. Sugerman, you have your slides up. You have the floor.
Thank you very much. I'm a medical officer within the Division of Viral Diseases at CDC, and in the end, it's probably good that I'm presenting remotely as I developed COVID-19 late last week. So I'm going to talk about our investigation into pediatric hepatitis of unknown etiology. Next slide, please. This all started with a cluster of cases identified by the Alabama Department of Public Health and treating clinicians at the UAB Children's Hospital of Alabama. There was a series of 9 children that presented with hepatitis and also adenovirus viremia, for which other causes couldn't be identified, between October of 2021 and February of 2022. They were negative for metabolic and autoimmune hepatitis. All 9 were adenovirus positive, 5 of which were adenovirus type 41, which is, along with type 40 in species F, the 2 adenoviruses that cause gastrointestinal symptoms, such as vomiting and diarrhea. It was also noted that the cases that progressed to liver failure, 2 of which required transplant, had the highest adenovirus viral loads. 7 were also co-infected with other pathogens that are known, some of which are known to cause viral hepatitis, like Epstein-Barr virus and enterovirus, as well as other circulating pathogens at the time, such as respiratory syncytial virus, RSV. None of these 9 cases were positive for SARS-CoV-2, and none were vaccinated. Only 3 were eligible because this initial group was quite young, as many of our cases are. Alabama put out a statewide notice to notify clinicians and to identify additional cases, and none were identified for some time. In April, the UK Health Security Agency also reached out to the US CDC's Division of Viral Hepatitis and noted an increase in acute pediatric hepatitis of unknown etiology. And they called to share information, and we did the same about our cases. Next slide, please. And with picking up this cluster in Alabama and then hearing of cases in the United Kingdom, we posted an advisory that went nationwide, alerting clinicians of the situation, suggesting they notify their public health agencies of any cases of acute hepatitis of unknown etiology and to perform laboratory testing for adenovirus. Next slide, please. Just as a basic review, hepatitis means inflammation of the liver. This is a general term, does not specify the cause of that lymphoinflammation. And there are many possible etiologies, infections, some of which I've mentioned, such as hepatitis viruses A through E, herpes simplex virus, Epstein-Barr virus, human herpes virus 6 or 7, and there are others. There's medication toxicity, such as Tylenol or acetaminophen, overdoses, mushroom toxicity, aflatoxins. There's immune dysregulation, autoimmune hepatitis, hemophagocytic lymphohistiocytosis, and other prior viral infections that can trigger immune dysregulation. And then metabolic diseases such as Wilson's disease, a copper storage deficit. It's also important to realize that at baseline, around 30% of acute liver failure is of unknown etiology. We don't identify the cause. And this number is likely larger when you look at pediatric hepatitis. And then finally, adenovirus 41 has been identified as a cause of hepatitis in immunocompromised children, but has never been described as a cause of hepatitis in immune-competent children. Next slide, please. As mentioned, we are staying in close coordination with the UK Health Security Agency, and they've put out several technical briefs. In their 3rd brief, dated May 19th, they mentioned having found 197 cases of hepatitis non-A through E in children less than 16 years of age. They describe a gastroenteritis type prodrome followed by the onset of jaundice. Adenovirus was detected in approximately 70% of the 170 cases tested, and all were serotype 41F of those typed. Community transmission rates of adenovirus were increasing in the United Kingdom since the end of 2021. They also detected other pathogens such as SARS-CoV-2 in 15% of the 169 tested, and human herpes virus, Epstein-Barr virus, CMV, RSV, and HSV. So their leading hypothesis was that this was caused by adenovirus, but there might be another cofactor affecting young children and rendering normal adenovirus infections more severe, causing them to trigger immunopathology. And they're continuing to also investigate the role specifically of SARS-CoV-2. Next slide, please. Globally, we now have around 650 cases. This is dated May 26 from the World Health Organization. Age range from 1 month to 16 years of age, with the majority, 75%, being less than 5. 12% of these cases have required liver transplantation. There have been 9 deaths reported. 61% of global cases are adenovirus positive, 12% positive for SARS-CoV-2, 73% positive by serology, though very few have actually had serologic testing for SARS-CoV-2. And the majority, about 2/3, have been reported from the United States and the United Kingdom with similar numbers of cases. Next slide, please. I'm going to pivot now to our specific investigation here in the United States. We're using the following definition to identify cases. Unlike the UK and WHO, we're focusing on children less than 10 as opposed to less than 16, with AST or ALT greater than 500, with an unknown etiology for their hepatitis since October 1st of 2021, which is about 2 weeks before our first case in Alabama on October 12th. We've used 2 additional data collection instruments, a case report form and an exposure questionnaire that is done through parental interview. Both are quite extensive, around 8 pages in length. Next slide, please. So what have we learned so far? We've received preliminary reports on 274 patients. This is from June 8th. We actually update our numbers weekly on up to 290 patients now, today. They're from 39 now up to 41 jurisdictions across the country. They're not clustered in one geographic location or at certain latitudes. They're also not concentrated in time. We've had reports between October and June. The majority of cases were hospitalized, more than 90%. 6% have required liver transplantation. We reported 9 deaths, and those are all under investigation. 46% have been confirmed with adenovirus, and of those, around 11 have been typed as 41. And there's no yet strong signal for other risk factors, toxins, drugs, other exposures. Next slide, please. We had initial pathology from Alabama, which did not demonstrate typical adenovirus hepatitis. And we've found the same in our pathology branch. There are degrees of acute hepatitis, but none of the changes are specific for adenovirus hepatitis. We've looked at 6 of the Alabama patients. There were no immunohistochemical evidence for adenovirus, no viral particles on electron microscopy, and they were also negative for SARS-CoV-2 enterovirus as well, PCR negative. We did, in the 2 patients that required liver transplantation, in the explants, the tissue removed, we identified adenovirus by PCR, though it's possible that that's blood contamination. We will complete testing on the liver tissue obtained from the 2 Alabama patients that were transplanted, testing on additional specimens from 15 persons under investigation that were either transplanted or received liver biopsies. And we're also developing and validating an adenovirus in situ hybridization, which will visualize the exact location of viral nucleic acid on tissue and help us better see if there's direct pathologic effect from adenovirus. Next slide, please. Here's our most recent epi curve that describes cases of hepatitis by date of onset of symptoms. You can see that there was a large increase in cases after we released our health alert notification, or HAN, on April 21st, and that cases have since declined towards a baseline. Next slide, please. So in review of our current investigation, we're certainly considering adenovirus as a principal cause, but it may not be the main cause or only cause. So we're exploring other potential exposures, medications, other infections, toxins, food, exploring cofactors such as SARS-CoV-2, keeping an open mind and casting a very broad net. We'll focus our investigation in time as we learn more, and we're certainly coordinating, as mentioned, with the UK Health Security Agency, but also the European CDC, WHO, Health Canada, and other public health agencies, including WHO headquarters. Next slide. I wanted to run through some questions and how we're addressing them with data. The first is, to what extent are we seeing a real increase? Is this an outbreak? I think that's the first question you think about when you have a cluster. Next slide, please. To answer that, we've looked at our emergency department data across the country. This represents 71% of all emergency department visits that occur. This is data for 0 to 4-year-olds. And if you look here, the red dotted line is our exceedance threshold. The cases here controlling for the pandemic period in gray, the cases in dark blue, the line to the right, during the period of interest have not crossed the exceedance threshold. And therefore, we do not feel we are seeing an increase in hepatitis-associated ED visits since October 1st of 2021 in comparison to the pre-pandemic baseline. Next slide. In addition, we've looked at hospitalizations for pediatric hepatitis between January of 2019 and March of 2022. And again, we've denoted the first Alabama case in mid-October. And during this period between mid-October and March, the end of March, we have not seen an increase for either children 0 to 4 or 5 to 11 above a baseline. Next slide, please. We've also looked at liver transplantation between January of 2017 and March of 2022, denoting the period here at the right after our first Alabama case, and again, not noting an increase in pediatric liver transplantation. Next slide, please. Our next question is, if this is primarily due to adenovirus, why is it happening now? Has there been a large adenovirus type 41 season, maybe an unusual strain? Next slide. This is data obtained from LabCorp for children 0 to 4 and 5 to 9 years of age, looking at percent positivity, the orange line, over time between October of 17 and March of 2022. You can see that the rates decline during the COVID-19 pandemic and increase, but that increase is not larger than the pre-pandemic baseline of adenovirus type 40 or 41 positivity. And these, again, are the two adenoviruses that cause gastrointestinal symptoms and were found in our early cases. The same is seen in those 5 to 9 years of age. Next slide. Next question was, what is the etiologic role of adenovirus, and specifically adenovirus type 41? Next slide. Looking at the hexon gene region of adenovirus 41, we've been able to sequence and map these sequences to known strains of adenovirus. There are 5 distinct strains that were obtained from our initial cases with specimens from Alabama. They're also 99% similar to known adenovirus strains. So it's appearing that this is not a new variant and is closely related to other circulating adenovirus type 41 strains that have been known. Next slide, please. I'd like to run through evidence that supports and refutes the role of adenovirus. First, this infection viremia is seen in more than 2/3 of patients across many countries, as reported by the World Health Organization. Limited data thus far shows a greater viral load in children who progress to liver failure and ultimately require transplant. The age group is also very typical, less than 5, for those that are susceptible and develop adenovirus. Many of our cases had preceding gastrointestinal illness. The most common symptom reported amongst all cases is vomiting. And there's no clear alternative hypothesis thus far. Next slide. And these are the questions that refute the role of adenovirus. It's not well recognized that it's a cause of hepatitis in healthy children. The pathology has not been consistent, as mentioned, with typical adenovirus hepatitis. Evidence of viral infection has not been detected in the liver as of yet. Metagenomic studies from the UK have not found adenovirus infection, though have identified adeno-associated virus 2, a deficient parvovirus not known to cause human disease. We're likewise looking at the role of adenovirus AAV2. Limiting sequencing data indicate multiple strains, as shared earlier, not one virulent strain that's mutated. Next slide, please. And then finally, are there other pathogens or cofactors, specifically SARS-CoV-2, that are playing a role? Next slide. And that could be from multiple different angles. First, acute SARS-CoV-2 infection leading to hepatitis. Recent SARS-CoV-2 infection triggering some sort of an immune dysregulation. Is there an overlap with the multi-inflammatory syndrome in children, or MIS-C? Is there persistent shedding of SARS-CoV-2 in the gut, triggering a superantigen reaction? Or could pandemic mitigation measures and the lockdowns where children weren't exposed to adenovirus and other viral illnesses also be contributing, in which when they were emerging from these lockdowns that they contacted adenovirus in a rapid way, and that triggered immune dysregulation? Next slide, please. First, we've looked at our MIS-C data and showed that amongst 8,000 patients in that database, we did see many had elevated liver enzymes, 51%, or elevated bilirubin, 21%. But very few had liver failure, less than 1%. And almost all of these had multi-organ system involvement and shock, not primary liver involvement. Next slide. I have a slide that apparently got dropped, but also in our cases, we've shown that less than 10% of them were co-infected with SARS-CoV-2 at the time of presentation, and with 90% admitted and now standard testing for SARS-CoV-2 at time of admission, we don't feel that it's as likely that children are at least having an immediate reaction to SARS-CoV-2 as that testing we can rely on. But we've also noted that about 1/3 of patients are reporting a history of prior SARS-CoV-2 infection, and we'll certainly need to understand if this might be part of a long COVID syndrome or a delayed sequelae of SARS-CoV-2 in some way. So in summary, our national data streams do not really indicate an increase in pediatric hepatitis ED visits or admissions, liver transplants, or adenovirus above the pre-pandemic baseline. Early sequence data does not support a new adenovirus variant with increased virulence. And also, few cases are co-infected with SARS-CoV-2 at presentation, but the role of prior infection or persistent viral shedding in the gut certainly needs further investigation. Next slide. We have many next steps. We're continuing to collect and describe our persons under investigation data. We're establishing a prospective hospital-based case control study, though enrollment will take time and likely won't have we won't complete enrollment until late October with analysis following. We're planning to test stool for SARS-CoV-2 to determine if there's persistent shedding, though there's not currently a validated assay, and so we'll work with a state lab to pursue that, as well as antibody testing on acute cases at CDC. There's also many targeted physiology investigations that will occur largely with partners or led by partners. The first is going to be, as mentioned earlier, led by CDC, which is looking at in situ hybridization. We'll do some of the metagenomics work and then work with colleagues at academic universities and NIH to do further metagenomics work. We hope to also work at NIH on growing adenovirus in liver cell culture and further work on immune dysregulation, looking at PBMCs with certain tagging markers like CD8, 103, autoantibodies, and other blood tests for immune dysregulation, such as T cell skewing in the repertoire of T cell receptors. Next slide. And just finally, wanted to share our website that's updated weekly with counts and has other general information on the outbreak and updates. Thank you.
Thank you very much, Dr. Sugarman. Very nice summary of a challenging set of investigations. Our next panel is on help eliminating the silent epidemic in America, new adult hepatitis B immunization recommendations. Although antiviral agents against hepatitis B have been widely applied to treat chronic hepatitis B, the drugs cannot eliminate the virus. Vaccination against hepatitis B, therefore, may be the most important strategy to control hepatitis B infections. The CDC's Advisory Committee on Immunization Practices recently issued a universal recommendation for all adults 19 to 59 years to receive hepatitis B vaccine and recommended those aged 60 and older with risk factors be vaccinated. This session will explore the new recommendation and strategies and innovative approaches to effectively operationalize this important recommendation for millions of adults. Our panelists are Dr. Cherry Cohen from the Hepatitis B Foundation, speaking about the burden of disease, Dr. Mark Wang from CDC and ACIP, talking about the new recommendation and ACIP evidence process, Dr. Rita Kuwahara from Georgetown University, talking about implementation, and finally, Dr. Carolyn Bridges from the Immunization Action Coalition, talking about challenges and opportunities in vaccinating high-risk adults. Dr. Cohen, you have the floor. Your slides are up.
Thank you so much. I'm very happy to be here today and want to thank you for including hepatitis B vaccine in today's meeting. Next slide, please. I'm going to give a little bit of a background of hepatitis B. It is one of the most common infections in the world. There are about 300 million people worldwide living with chronic hepatitis B infection. And though we don't talk about it much, it is the world's leading cause of liver cancer. In the US, almost 2.4 million people are living with chronic hepatitis B. And we are actually seeing a rise for the first time in 2 decades in acute hepatitis B infections over the last few years. We do have good treatments for hepatitis B, but no cure as of yet. The vaccine for hepatitis B is the first anti-cancer vaccination ever FDA approved because it prevents liver cancer. There are 5 vaccines available in the US. Some are used for kids and some are used for adults. And we are going to talk a little bit today about the role of the hepatitis B vaccine in Hep B elimination in the US. Next slide, please. As I said, there are about 2.4 million people in the US who are chronically infected. We see in the US about 20 to 50,000 new infections annually, but that's a really hard number to pin down because we do not have routine active surveillance especially for chronic hepatitis B in the US. And even for acute hepatitis B, it's spotty, so most people go undiagnosed. Among chronic infections here in the US, about 75% go undiagnosed, so only a small percent of people are aware that they have the infection. And because of that, most of the people who have it are unable to take medication. They're unable to take advantage of the medication that could help prevent liver cancer and cirrhosis of the liver. And what we know is that even when people are diagnosed for hepatitis B in the US, they are very often unable to access appropriate care and treatment. So we have multiple gaps in the entire care cascade, from vaccination and prevention to diagnosis to treatment and liver cancer surveillance. Next slide, please. We care about liver cancer. We care about hepatitis B because we care about liver cancer. Liver cancer is unfortunately one of the most severe outcomes of hepatitis B. And what we know, very much like the trend we see globally, is that liver cancer is on the rise in the U.S. and has been since 2013. It's been one of the fastest growing cancers in both men and women, in both incidence and mortality in the U.S. And, part of the problem here is that liver cancer is also one of the most deadliest cancers. There are no real great treatments for it. And so the 5-year survival rate is pretty low at 20%. The other thing to note is that recently we've actually seen in some studies across the U.S. that liver cancer induced specifically by hepatitis B is growing, so that more people now that a larger proportion of people who have liver cancer now in the U.S. seem to have it from hepatitis B than before. Next slide. We also care about hepatitis B here in the U.S. because of the tremendous health disparities that are associated with both Hep B and liver cancer. So here, Asian Americans, Pacific Islanders, Native Hawaiians, and African immigrant communities are more impacted by hepatitis B. They are disproportionately impacted. In fact, Asian Americans and Pacific Islanders make up about 50% of the total chronic Hep B burden in the U.S. And if you look at the liver cancer death rates, they are much higher among Asian American, Pacific Islander, and African men in the U.S. Next slide. Unfortunately, we are at the same time that we're seeing liver cancer rise and we're seeing high rates of Hep B, both chronic and acute, we are also seeing low coverage rates among adults. We have a very effective childhood vaccination program. It's over 90 to 95% in most places around the country. However, only about 25 to 30% of adults have been vaccinated and are protected against hepatitis B. And if you look at the slide here, you can see that it varies. These are the vaccination rates among some of the risk groups. And you can see, for example, especially among healthcare providers, we've not done a great job of improving those rates. And so we're nowhere near the Healthy People 2020 target. And we're not necessarily making any inroads recently in improving adult hepatitis B vaccination rates. Next slide. Why are coverage rates so low? Well, it's complicated, and there are many reasons. One of them is that right up until November of 2021, adult hepatitis B vaccine recommendations were risk-based, and the risk groups were wide and varied, and between 12 and 15 risk groups could be identified. And we all know how difficult it is to implement in the field risk-based recommendations, especially when some of those risks are potentially stigmatizing. And so in a lot of cases, providers were de-incentivized from asking about risks, and patients who were not aware of their own risks or didn't want to talk about their own risks were feeling as though they didn't want to necessarily disclose a behavioral risk. So you had a situation where a lot of people haven't been vaccinated for hepatitis B because awareness is low, because risk-based vaccination is very hard to implement. And because of the risk-based recommendations, there were certainly challenges with reimbursement. One of the other issues to remember here, and I know this slide shows it, is that if you look at the number of acute infections, this is from 2019, I think, look how many people had no risk identified, right? So 30% had no risk identified. So if you're implementing risk-based vaccination, you're going to certainly miss people who just have no known risk. Next slide. We now have an incredible opportunity to improve adult hepatitis B vaccination coverage in the U.S. We have a very exciting new universal recommendation for all adults between the ages of 19 and 59 and adults 60 and over who have risk factors. So this is an incredible opportunity for us. We can now make sure that adults between the ages of 19 and 59 are vaccinated with no cost sharing. So a lot of the financial and systemic barriers are going to be removed for many adults here. It's going to be easier for people to access vaccine. Also, it's going to be easier for providers to implement universal vaccination for adults. No questions asked. So we don't have to ask any questions anymore about risk factors. That's gone as a barrier. It reduces quite a lot of the stigma associated with hepatitis B vaccination and with hepatitis B overall. we really feel strongly that the universal vaccination recommendation will help eliminate hepatitis B, which we in the U.S. have committed to doing, and it will help eliminate the health disparities that are associated with the infection. Next slide. So before I turn it over, again, an exciting opportunity for us, but as I think everyone in the room knows, it will be a challenging task. The good news is that we can learn from the programs that have come before us. You know, hepatitis C went from risk-based screening to universal screening. Flu went from risk-based vaccine to universal vaccine. So we do have lessons that we've learned from others. I think the important thing moving forward is that we are going to have to widely promote these expanded recommendations so that all of the stakeholders know, that providers at every level and communities know that these universal recommendations exist. We're going to have to work to address vaccination hesitancy. We're going to have to work to increase demand for the vaccine, especially among high-risk communities. And I think we can do that when we make sure that all stakeholders are part of the implementation plan, especially as we're bringing communities to the table. One of the things that we have seen work in hepatitis B is patient engagement and people sharing their stories about hepatitis B vaccine and about prevention and living with the virus. And so we will be working with partners around the country over the next few years to implement these recommendations and are very excited to have partners, many of whom are in the room. And I think that is it for me. Next slide, please. So just want to say thank you, and I look forward to the rest of the session.
Thank you very much, Dr. Cohen. Our next presenter is Dr. Mark Wang from the Centers for Disease Control and Prevention. You have the floor, sir.
Thank you. Thank you, Dr. Cohen. Good afternoon, everybody. I'm Lieutenant Commander Mark Wang with the CDC's Division of Viral Hepatitis in Atlanta. Thank you for inviting us here today to speak with NVAC. I'm excited to be sharing with you today the update on universal hepatitis B adult vaccination recommendations. I have nothing to disclose. In late 2021, the Advisory Committee on Immunization Practices, or ACIP, voted to recommend that the following groups should receive hepatitis B vaccines: adults aged 19 through 59 years, adults aged 60 years and older with risk factors for hepatitis B. The ACIP recommends the following groups may receive hepatitis B vaccines: adults aged 60 years and older without known risk factors for hepatitis B. Today, we'll discuss the rationale behind this ACIP decision and how it can help us achieve HHS hepatitis elimination goals by 2030. You've just heard from Dr. Cohen about the estimated 20,700 estimated acute hepatitis B infections in the US every year. There's also over $1 billion spent on hepatitis B-related hospitalizations. You've also heard from Dr. Cohen about that there are up to 2.4 million people estimated to be living with chronic hepatitis B in the US, of whom there's a 15 to 25% risk of premature death from cirrhosis or liver cancer. The ACIP hepatitis vaccines work group's goal was to examine Hep B vaccine policy and propose strategies that are most effective at preventing new infections and hepatitis B-related cancer and death. The Hep B immunization strategy has evolved over the past 4 decades. Risk-based strategies were first introduced among adults and perinatally exposed infants in the early 1980s. Then, universal infant vaccination was introduced in 1991, with catch-up vaccination recommendations for adolescents in 1999, followed by the introduction of universal birth dose from all newborns in 2005. All these steps towards routine Hep B vaccination resulted in large declines in new hepatitis B infections among children and adolescents. However, hepatitis B incidence has plateaued over the past 10 years, with more than 20,000 new infections estimated to occur each year. This slide summarizes the limited Hep B vaccine coverage among adults in 2018. Overall, coverage was 30% for adults 19 years and older. Reported coverage rates were likewise low across risk groups, including travelers, people with chronic liver conditions, and people with diabetes, with particularly low rates among older people with diabetes. Surprisingly, among healthcare personnel, Hep B vaccination coverage was only 67%, which, as you've heard, is far short of this group's healthy people 2020 target of 90%. The past decade has illustrated that risk-based screening among adults has got us as far as it can take us. Initial decreases in new infections have stagnated. Rates of acute infections are now highest among 30 through 59-year-olds. And rates have actually increased among adults 40 years and older, indicating that we are losing ground. We cannot eliminate hepatitis B in the US without a new approach. It's important to recall that only 1/3 of people with reported acute hepatitis B actually reported any risk factors. For the remaining 2/3 of reported acute infections, indicated in yellow shading here, the previous risk-based vaccination strategy among adults provides no advantages in identifying and vaccinating people who had either denied any known risk or simply lacked any risk data. Racial disparity in hepatitis B infection rates showed slow improvement under the risk-based Hep B vaccination strategy. We point out that after the universal Hep B vaccination strategy for children and adolescents was implemented, rates of HBV disease for children and adolescents of all races did converge to a lower rate. After 24 years of the risk-based policy, first recommended in 1982, among non-Hispanic Black Americans, HBV infection rates did decline, but remained over twice as high as among several other racial and ethnic populations. Most new HBV infections occur in adults aged 19 years and older, and the rates among Black Americans are up to 3 times those of Asian Pacific Islander and Hispanic Americans. Furthermore, data from the 2019 surveillance report also showed that HBV infection rates have increased among non-Hispanic white Americans due to outbreaks among people aged 30 to 39 years and who use injection drugs. It's in this context that the ACIP hepatitis vaccines work group proposed that the existing risk-based Hep B vaccination strategy is expanded among adults and simplified to a universal recommendation. This slide highlights the updates to the Hep B recommendation. As you see on the left, risk-based recommendations among adults are complex and include 15 specific behavioral and non-behavioral risks in 3 categories, such as sexual exposure, percutaneous or mucosal exposure to blood, household contact with someone living with hepatitis B, diabetes, or other, such as travel or having chronic liver disease. I'm sure you're just as out of breath as I am trying to list them all out. Moving to a universal vaccine recommendation among adults serves as a natural extension of existing routine childhood vaccination recommendations. For adults aged 19 through 59 years, the risk factor assessment is eliminated, and this collapses the numerous existing adult risk groups on the left into a universal recommendation on the right to receive Hep B vaccines in this age group. All infants, children, and now adults 19 through 59 years of age. For adults 60 years of age and older, the Hep B recommendation is similar to the 2018 recommendations and uses the same risk factors assessment for this older age group. In previous Hep B recommendations, providers were advised to administer Hep B vaccine to all patients who requested it. The new language is intended to prompt all providers to offer Hep B vaccination to individuals in the cohort aged greater or equal to 60 years, rather than wait for a patient to request vaccination, and thus shifting the responsibility of initiating the consideration of Hep B vaccination from the patient to the provider. One of the reasons for this age cutoff is that among the cohort aged 60 years and older, hepatitis B incidence is markedly lower at about 0.6 cases per 100,000 population in 2019. And thus the preventable burden of disease in that age group is lower than for those aged 19 to 59 years. In February 2022, ACIP recommended a 3-antigen hepatitis B vaccine called Brihevbrio. Brihevbrio, given in 3 doses, may now be used as a Hep B vaccine in persons aged greater or equal to 18 years, recommended for vaccination against HBV infection. Please note that due to insufficient data at this time, persons on hemodialysis, pregnant persons, and persons who are breastfeeding were not discussed in the evidence to recommendations framework leading to the ACIP decision. And just a further note on Heplisab-B and PreHevbrio in dialysis or pregnancy. The safety and effectiveness of Heplisab-B and PreHevbrio have not been established in adults on hemodialysis. Data are not available to assess the effects of Heplisab-B and PreHevbrio on the breastfed infant or on milk production and excretion at this time. Data on Heplisab-B and PreHevbrio are currently insufficient to inform vaccine-associated risks in pregnancy, and thus providers should vaccinate pregnant people needing Hep B vaccination with Injirix, Recambavax, or Twinrix. So in light of the new updated universal Hep B recommendations, here's a table of adult monovalent Hep B vaccines, so some tools at your disposal. PreHevbrio is a mammalian cell-derived alum-adjuvanted 3-dose hepatitis B vaccine. PreHevbrio, like the previously approved Injirix and Recambavax, are all 3-dose vaccines. Injirix and Recambavax contain the small S antigen, while PreHevbrio contains the S antigen in addition to the pre-S1, pre-S2 antigens, hence the 3-antigen vaccine. Heplisab-B, approved in 2018, is adjuvanted with CpG 1018 and is a 2-dose single antigen vaccine. Twinrix, the combination Hep A, Hep B vaccine, is not shown here, but can also be used to protect adults against hepatitis B infection. But of course, we all know that old chestnut, that vaccine doesn't save lives, vaccination saves lives. And I'm looking forward to hearing more from Dr. Kuhara and Dr. Bridges, who follow me on the way forward on that. To summarize, in the context of the call from HHS and National Academies of Science to eliminate viral hepatitis, there are multiple examples and evidence where universal is preferred to risk-based approaches to lowering barriers to vaccination. This is in line with public health principles and practice. ACIP reviewed these examples along with the hepatitis B infection rates, dynamic risks of hepatitis B over everyone's lifetime, and health equity observations. ACIP concluded that by relying on previous risk-based recommendations, focusing only on the slow, bottom-up approach of vaccinating all children who will then take their immunity with them when they reach adulthood would be a disservice to a large portion of the US population. Plus, the previous risk-based policy creates obstacles for the provider to identify risk and for the patient to self-advocate, which is a particularly challenging barrier for people in vulnerable and medically underserved communities. What else is different this time compared to 1982, when risk-based Hep B recommendations were first introduced? Today, we have a growing toolbox, new access points for vaccination that eliminate this potentially fatal virus. There are now 2 single antigen, 3-dose vaccines available, safe, effective, and with long-term immunogenicity, 1 2-dose vaccine, which is safe and effective. There's also 1 combination vaccine, and there's 1 3-dose, 3-antigen vaccine that was recently approved. ACIP concluded that the universal recommendation would allow the US to leverage this growing toolbox for public health and equity goals. With an eye towards implementation, this universal recommendation dovetails with the ongoing expansion of viral hepatitis surveillance, renewed focus on vaccination delivery, improved integration of services, and expanded immunization venues. Plus, by late 2022, we're anticipating CDC recommendations for one-time hepatitis B screening guidelines for all adults. Hepatitis B is vaccine preventable. Safe, effective, cancer-preventing vaccines have been available for over 40 years, but the previous risk-based Hep B vaccine policy was proving to be a barrier to public health objectives. And for these reasons, we believe a universal hepatitis B vaccination recommendation among adults aged 19 through 59 will provide a better chance of achieving hepatitis B elimination goals in the United States. With thanks to the members of ACIP Hepatitis Vaccines Work Group, and followed by references. Thank you.
Thank you very much, Dr. Wing. Our next presenter is Dr. Rita Kuwahara from Georgetown University. Dr. Kurihara, your slides are up. You have the floor.
All right, thank you. Thank you for the opportunities to speak to you today about strategies to implement universal hepatitis B vaccination for adults aged 19 to 59 years old. I'm Rita Kawahara. I'm a primary care internal medicine physician and also serve as co-chair of the Hepatitis B Screening and Vaccine Advisory Council, along with Dr. Sherry Cohen, who you already heard from today. Right now, with the universal vaccination guidelines, we have an incredible opportunity to finally eliminate hepatitis B in the United States. However, we have to be really mindful about how we implement the new recommendations so that we can be most effective in doing so. And we really do need to adopt a multi-pronged strategy to implement the guidelines, which include increasing clinician awareness of the guidelines, ensuring adequate infrastructure and funding, developing clinical protocols to implement the guidelines, strengthening our partnership with pharmacies, addressing high-risk populations, making sure that our messaging aligns with currently the screening recommendations that are being updated at this time, and ensure that the messaging that we develop to the public is most effective to allow uptake of the guidelines. So I'd like to start by talking about raising clinician awareness. We did a survey of 900 family physicians across the country recently and found that 55% of the surveyed physicians were not aware of the updated universal guidelines for adult hepatitis B vaccination, and only 8% were actually implementing the guidelines in daily practice. In addition, nearly 2/3 of the surveyed physicians realize that only 30% of US adults are vaccinated against hepatitis B. So this represents a lot of opportunity where we really need to focus on increasing clinician awareness by either partnering with medical societies to focus on clinician education, but also working within academic centers and other training programs so that our trainees are aware of this. And while we increase awareness of the universal guidelines, we also need to increase awareness of the different vaccine options available, including the 2-dose HEPLISAV-B vaccine that has been available for a couple years. In implementing any new guidelines, it's critical that we have adequate infrastructure and funding to support implementation. And this needs to occur at the federal, state, and local levels. Specifically, increasing Section 317 funding will be an important next step so that we have increased funding for those without insurance to be able to access the vaccines. In addition, the president in the most recent budget introduced a Vaccines for Adults program. It'll be critical to establish this program as well as fully fund it. And while we have some resources available to those without insurance, many resources are not available to the underinsured. So we need to specifically look at that side of it and build upon existing COVID-19 vaccine infrastructure that we've already developed to then implement the current guidelines. In addition, we need to develop a federal immunization information system so that we can really track the vaccines that are administered across the lifespan, regardless of where a person might live if they move from state to state. Another key component for implementing the universal hepatitis B guidelines is to ensure that we develop clinic protocols to support the implementation. So this includes stocking the hepatitis B vaccine in clinics, but also to make sure that standing orders exist so that regardless of why a patient might come into the clinic, if they're eligible for the vaccine, that they're offered it and they can get it at that time. We also need to make sure that all members of the healthcare team are ready to discuss vaccination and create other electronic health record alerts so that it can remind clinicians when patients are eligible for vaccination, and make sure that information is available in multiple languages to our patients. And also we need to update our clinic protocols when we're talking about specific diseases such as diabetes so that we include vaccination as a part of those recommendations. And lastly, it's really important to create patient reminders. Because hepatitis B is a multi-dose vaccine, it's critical that patients return to receive the subsequent vaccine so they are able to complete their vaccination series. And one of the key components to developing reminders is before a patient leaves wherever they're getting their vaccine to have that next appointment set up so that they return, and then create several other innovative ways to remind patients to return. And we can learn a lot of lessons from other multi-dose vaccines like the HPV vaccine that is already available. In addition, we really need to partner with our pharmacies. As we've seen with COVID-19, patients are able to access vaccines in a number of settings, and it will be wonderful if patients can get the vaccines in pharmacies, but we need to strengthen the pharmacy clinic communication so that when a patient receives a vaccine in the pharmacy, that information is transmitted back to a patient's primary care clinician. We also need to make sure that vaccines that are covered in clinic settings are also covered in pharmacies with no cost sharing for patients. And again, focus on the reminders so patients return for the subsequent doses of the vaccine. It's also really important that while these are now universal guidelines up to age 59, that we still have a special emphasis on addressing reaching out to the highest risk populations, including Asian Americans and Pacific Islanders, African immigrants, and persons who inject drugs. Some of the strategies that we might want to adopt include partnering with community outreach programs that are already very familiar with communities that they're working with so that we're able to implement the vaccines in the community setting. Also making sure that, again, this information is available in multiple languages, that vaccines are available in non-traditional sites such as their in-service programs and other outreach programs. And then another part of this is that in the guidelines, although it's universal vaccination up to age 59, ACIP also said that adults 60 and up with risk factors should receive the hepatitis B vaccine. So to implement that second part of the guideline, we need to really make sure that we're connecting with the highest risk communities as an issue of health equity. There are a few other additional financial considerations that need to be taken into account. The ACIP, in addition to the universal guidelines to 59, said that adults 60 and up without risk factors may receive the hepatitis B vaccine, but we need to make sure that if patients decide that they would like to get the vaccine, that these are covered by insurance and other payers with no cost sharing for patients. We also need to make sure that if patients receive the vaccine in non-clinic settings, that they can be administered and be reimbursed in those settings, especially when partnering with community outreach programs and other events. And again, as I said earlier, making sure that resources available to vaccinate those without insurance and those who are underinsured will be really critical. And again, making sure that patients don't have out-of-pocket costs associated with vaccines will be important for uptake. As we're developing messaging to implement universal hepatitis B vaccinations, we need to make sure that we're in alignment with the hepatitis B screening recommendations that are currently being updated by the CDC. And the CDC had put forth a draft proposal recommending universal hepatitis B screening that had closed public comment earlier this month. And so we hope to see updated recommendations coming up in the coming months. But as we develop our messaging around vaccination, we need to make sure it aligns with screening. We also need to, another thing that's come up though is that because the U.S. Preventive Services Task Force has recently updated the screening recommendations that maintain the risk-based screening a couple of years ago, we need to make sure that when the CDC updates their recommendations, as we anticipate they will, that payers will be able to cover those tests without cost sharing for patients, and that that's also addressed. And then, of course, when screening patients for hepatitis B, if someone's positive, we really need to make sure that they're appropriately linked to care. And finally, when developing strategies to implement the universal vaccination guidelines, we really need to be mindful of how we create public messaging. And a lot of it is around the way we frame our messaging. In this case, it'll be really important to talk about hepatitis B vaccine as the first anti-cancer vaccine that was developed. And we need to avoid politicizing and stigmatizing vaccination, which has become quite an issue recently. In addition, because community organizations know the community best, we need to partner with our community partners in order to develop the most effective messaging for the public. And any mass communication strategies that we adopt need to be available in multiple languages. And finally, because many of these conversations happen between the clinician and patient, we really need to focus on the importance of having that conversation. And that loops back to making sure that primary care clinicians are aware of these guidelines so that we can implement them universally. All right, thank you.
Thank you, Dr. Kuwahara. And our final presenter in this panel is Dr. Carolyn Bridges from the Immunization Action Coalition. Carolyn, your slides are up. You have the floor.
Thank you very much. So I was asked to talk about hepatitis B vaccination in high risk, and I'm going to do that by providing a summary of a pilot project that was done among high-risk persons in 2012 through 2015. Next slide, please. The disclosure I have is that I have done consulting with NVAC on their scientific advisory board, for which my time is compensated, but that was done only after the completion and publication of the study, and I will not be discussing any specific vaccine products. Next slide. And you can find the link to the publication below that this talk is based upon. So this pilot project was done with the aim to reduce hepatitis B among high-risk adults, and it was funded through the Affordable Care Act, prevention, and public health funding. This pilot project was built upon a 2007 to 2009 immunization program hepatitis B project. That project did not include operational funds for the health departments, which was cited as a significant factor contributing to implementation challenges. Next slide. So for this study, funding was provided for operations, and vaccine was provided in kind to the health departments. All 64 U.S. immunization programs were eligible to submit proposals, but those with a higher incidence of hepatitis B and those who were able to initiate their project within the same fiscal year were prioritized for funding. They were required to use evidence-based strategies to improve vaccination rates, and they were requested to use immunization information systems for tracking. But just as a reminder, this was 2012 to 2015, and I think we've come a long way with our registries since that time. Next slide. So the 14 programs selected, or the awardees, are listed here. Out of the 14, 12 requested an additional extension a year. So most of them actually had 3 years for this study. They collected information on doses that were administered, vaccination location types that were utilized, vaccine dose series completion, and the challenges and facilitators to vaccinating high-risk adults against hepatitis B. Next slide. So overall, about 161,000 hepatitis B vaccine doses were ordered and distributed to the 14 awardees. About 91%, or 147,000 doses, were administered over the 3-year period. About 5% of doses were unused, and about 4% of doses were wasted due to expiration of doses or interruption in the cold chain. Next slide. The awardees used a total of 459 different facilities or settings to administer hepatitis B. The vaccine was not to be used for healthcare workers, or international travelers, or persons with or who are on dialysis. So the emphasis was really on correction facilities, drug treatment programs, health departments, HIV clinics, and STD clinics. The most frequently used site was health departments, followed by corrections and STD clinics. Next slide. So among persons who received hepatitis B vaccine and for whom the health departments were able to track reporting of risk factors, as other presenters have shown, a large proportion did not answer or did not report a risk factor for being able to receive hepatitis B vaccination, but wanted to get vaccinated. The next most common risk factor was being evaluated for a sexually transmitted infection, and then followed by having more than one sex partner or having diabetes. Next slide. Only 6 of the 14 awardees were able to report dose series completion in this pilot project. And as you'll see, of those who received dose 1, about 40% of people received dose 2. And of those who received dose 1, only about 22% of people received dose 3. So we had a relatively low 3-dose series completion. And just to remind everyone that a 2-dose vaccine was not available at this time. Next slide. So those facilities that were more likely to provide more ongoing services, such as local health departments and other healthcare settings, such as those that cater to men who had sex with men, they tended to have higher, at least 2-dose series completion, as did FQHCs and some other settings. But the highest 3-dose series completion was among local health departments. We noted that in a number of different settings where there may be a stigma to coming back for follow-up visits, they tend to have lower 3-dose series completion, and in correction facilities as well, there's a lot of movement of persons in those facilities, and 3-dose completion was very challenging in that setting, as well as in drug treatment facilities. Next slide. So among the health departments that were part of the pilot project, the challenges that they noted were overestimation of vaccine needs and vaccine uptake and acceptance by the persons that were seen in the facility types that they utilized. They also had quite a bit of challenge with staff hiring and turnover, and being able to add vaccination to already overworked staff. There just was a real challenge in adding any kind of vaccination evaluation, and particularly with adding time for looking at vaccinations in registries and also data entry into registries. There was quite inconsistent use of the vaccine registries across sites. And in particular, they noted real challenges with mobile populations coming in for dose series completion. Some of the facilitators for hepatitis B vaccination for these high-risk groups included beforehand confirming their partners' vaccination capacity and their population's needs, and identifying clinic site vaccination champions that would really help ensure fitting hepatitis B vaccination assessment into the patient flow, as well as reporting to the registry. It was also important to have buy-in from all the frontline staff and to provide the vaccination sites with infrastructure funds for supplies, vaccine storage, and staff. They also conducted training and retraining of staff for registry entry, as there was, in many of these settings, quite a bit of turnover in staff over time. And they also noted that the use of evidence-based strategies remained helpful in these high-risk environments, including reminder recall, use of standing orders, and ensuring the vaccine was available at convenient times and locations, and particularly community events were successful. Next slide. So moving forward, of course, I think as others have mentioned, there are some significant opportunities here for this particular population, and removing barriers related to stigma will be important, as well as improvements in immunization information systems and vaccine registries. Over time, this should really help with dose series completion and vaccine needs assessment, especially for more mobile populations. However, even with these improvements in infrastructure with COVID-19 vaccine program, we still need for providers to implement NVAC standards for adult immunization practice. That really remains critical to actually improving vaccine uptake, both for hepatitis B and other historically low adult vaccination rates. So helping providers routinely assess adult vaccination needs at every encounter, making sure that they have a clear recommendation for vaccinations that's given to patients, and then either offering vaccine or for clinics that do not stock particular vaccine, referring to another vaccine provider and ensuring that these immunizations are all documented in vaccine registries is all important for making this universal hepatitis B vaccine recommendation, making sure it's successful. Next slide. There are many resources at CDC as well as at immunize.org and others for helping with implementation, not only of hepatitis B vaccine recommendations, but other adult vaccines. So I leave these resources for your information. Thank you so much.
Thank you, Dr. Bridges. And I want to thank Dr. Kawahara, Dr. Wang, and Dr. Cohen for your presentations. Again, we're running a little late on time. If individuals have comments or questions for our presenters, if you'll send those by email to Ann and I, we will get those to the presenters. Thank you again for your presentations. Our next and our final panel for the day is Moving the Needle, Injection-Free Inoculations. Advances in vaccine delivery hold promise to improve safety by decreasing inadvertent needle sticks, and some may even improve efficacy. This session will explore oral, intranasal, and intradermal vaccine administration. Our first presenter will be Dr. Myron Levine from the University of Maryland, presenting an overview, followed by Dr. David Fernandez-Rivas from the Massachusetts Institute of Technology on new needle-free innovations, Dr. Gunilla Jacobson from Stanford University on 3D printed microneedles, Dr. Xiaomin Tian from University of North Carolina, Chapel Hill on 3D printed microneedles, and Dr. Jillian Perry from UNC Chapel Hill on 3D printed microneedles. And our final presenter will be Dr. Daryl Irvine from Massachusetts Institute of Technology on an inhaled vaccine. Dr. Levine, thank you for being here with us. You have the floor.
Thank you. Good afternoon, everyone. I was asked to give a brief overview of needle-free immunizations and then to focus on mucosal and particular oral immunizations. So I will try to do that. If we look at all the vaccines used in populations in the world, from space, we see that in both the developing countries and the US and other high-income countries, they're given through routine healthcare, but they're also given through mass campaigns. In developing countries, in particular, the interest in needle-free is for reasons of injection safety in places where there's still HIV prevalence and hepatitis C and hepatitis B. And in the US, much more so in terms of parent preference. We also use these vaccines in mass campaigns, and with COVID, we've seen the importance of that. In what I would call the modern era, which I will define as since the establishment of the expanded program on immunization by the World Health Organization, there have been 4 initiatives that have had a great impact on interest and moving the needle for needle-free immunization. The first was 1990, the year of the child, when the UN agencies came up with what they agreed upon was the most important intervention in the previous decade that had increased child survival. And they came up with an aspirational children's vaccine, which would start with DPT and would add all the other needed antigens as multivalency or in combination. And that would not require a needle and syringe to be delivered. It would not need a cold chain. It would be resistant to freezing and to high temperature, and it would accomplish this with a single dose. Clearly, this was highly aspirational. The Children's Vaccine Initiative only lasted for 8 years. It had problems. And in this town, the World Bank convened a meeting in March of 1998 to address the problems that were continuing in terms of coverage and lack of introduction of new vaccines in the less developed world. And a task force was created to look at how to improve on the CVI. And out of that came the Global Alliance for Vaccines and Immunization, which is still a great success. The next initiative was after the September 11th, 2001 destruction of the World Towers and anthrax letters being sent in this across the East Coast, this so-called anthrax worry, and this put the U.S. into the biodefense era with great interest then in mass immunization with anthrax and smallpox vaccines. Next came the H1 pandemic and the COVID-19 pandemics. And once again, we recognize the importance and need for being able to deliver vaccines efficiently and ideally without needles. There are two major approaches to accomplish that. One is using mucosa as the inductive sites, in particular oral, but it could be any mucosa, rectal, vaginal, conjunctival, nasal. And the other broad approach is to take the antigens and put them through the skin, but without the need of an actual needle. And this includes a variety of needle-free jet injectors, hydrating the skin so that it becomes permeable, and whole new technologies, some of which you'll hear about today, microneedle array patches of a variety of different types. Going to oral vaccines, some of the rationale for administering orally include the following. You see that picture. If all vaccines could be developed, could be administered with the ease of Sabin polio vaccine, we would be having a very different type of meeting today. That delivery, that vaccine eradicated two viruses, poliovirus type 2 and poliovirus type 3. In the USA, oral or non-injection is clearly preferred by almost all parents, and for those kids who can speak, by kids themselves. It, in the developing world, but also in the US, avoids the problem of injection safety, and it's not well appreciated. But if you choose your antigens carefully, perhaps needing certain adjuvants or live vectors, you can stimulate any and all arms of the immune system by mucosal delivery. Attenuated Salmonella typhi strains, for example, stimulate serum antibody, mucosal antibody, CD4, and MHC1 restricted CD8 cytotoxic lymphocytes. It does it all. It also allows antibody in conjunction with certain phagocytes to kill powerful pathogens. For certain diseases, gonorrhea, for example, arguably influenza, perhaps COVID-19, SARS-CoV-2, mucosal pathogens, this can and perhaps should be a preferred way of delivering vaccines. It's an early defense even for invasive organisms, where the first defense is to keep it from going through the mucosa. One oral vaccine has shown protection for as long as 7 years, and another has shown that it gives very solid protection as early as 8 to 10 days after administration. And they are respectively oral TY21A typhoid vaccine and CVD103 HGR cholera vaccine. Those 2 FDA licensed vaccines available in the US are also accompanied by 2 rotavirus vaccines, Rotatec and Rotasix, Rotarix, pentavalent and monovalent rotavirus, respectively. I'll just mention with live bacterial vaccines that we've also learned how important the formulation is. You can have the same vaccine strain, but how you deliver it is the difference between really good protection and almost no protection. Similarly, the immunization schedule is very important. Want to stress again that along the mucosa are these inductive sites that consist of aggregates of lymphoid tissue covered by a microfold cell, which is an antigen processing or entry cell. And below that, all these immune competent and important cells. Some pathogens are well aware of these little lapses in the mucosa, such as Salmonella and Shigella, and they actually target entry through that. But this is a great way to get immune responses. Some jet ejectors you see here, some are approved for clinical use, such as the BioJet 2000. PharmaJet has a couple of different ones that are available. And then there are some that have been under development and that, to my knowledge, are not yet available for clinical. One that interested us back in the biodefense days was Electrojet. On the bottom left of this slide, you'll see an inspirational invention by Charles Méliès, who thought that if you had a simple device using spring loading that would send an antigen by pressure through the skin without a needle, and if you had a little cartridge in which contained vaccine, using the analogy of 35 millimeter cameras of the time, didn't matter whether you had a Nikon or a Olympia or a Kodak. If they all used 35 millimeter film, and it didn't matter whether the film was made by Kodak or by Fuji. That was his concept. And he tried to get the other manufacturers across the world to join in. They wouldn't do it, but it was an interesting idea. In the bottom right is the famous PedoJet, which allowed mass vaccination in some places during smallpox. With using the skin, the key is to get past the stratum corneum, which is the protective physical barrier. And you can do that, as mentioned, in a lot of different ways. You can do it by putting a wet patch for a few hours. You could do it by scratching. You could do it with microneedles. And what you want to get at below that are the Langerhans cells and other dendritic type cells. Let me finish up with what's special about adjuvants and mucosal immunization. With parenteral immunization, there are a number now known adjuvants. Not so many years ago, there was only alum. But the problem with mucosal immunization is that if you give a very powerful adjuvant, you're giving it to a surface that has microflora, microbiome, and also is experiencing an antigen load, just like we all had at lunch. It's constantly exposed to foreign antigen, and it's then fine-tuned so it's tolerant. If you give a powerful adjuvant that breaks that tolerance, problems can arise. And the last thing to mention is that with populations in developing countries, the same vaccines that work great in the USA don't work as well. A rotavirus experience is an example. In the 1990s, there was great interest in the use of cholera toxin and heat label intratoxin, originally as parenteral antigens. These are very, very powerful adjuvants, but you couldn't use them mucosally because 25 micrograms of of CT can cause cholera gravis, and 5 micrograms can give pretty bad diarrhea. And to get around that and still use these as mucosal adjuvants, the innovations were to create non-toxic LT and CT mutants and to administer them intranasally rather than in the gut. You don't get diarrhea in the nose. This led to some concern shown in this slide in that if you look in the nose, there's the cribriform plate, which you can see in both those photographs, which are little holes in the base of the ethmoid bone through which the olfactory nerve passes and is then contiguous with the olfactory lobe of the brain. There was a nasal flu vaccine that was licensed in Switzerland consisting of the inactivated virusome vaccine of this company, Swiss Serum Vaccine Institute of Berna, and that was given along with LT. And in animals, there had been no evidence of problems, and in their pre-licensure clinical trials, there was no problem. This was with wild-type LT, and it was very, very immunogenic. And it was used in the 2000-2001 flu season in the German-speaking part mainly of Switzerland. And this was followed by an outbreak, a great number of reports of Bell's palsy, which in that picture shows what you get, a drooping of the mouth and some tearing and a drooping of the eyelid. A case control study, an epidemiologic investigation was done by the CDC and the University of Zurich, and they clearly incriminated this vaccine given nasally, whereas the same vaccine given parenterally, there was no incrimination. But no one can figure out, it was assumed that this was due to the LT, but they couldn't prove it. And this was proven later by Professor David Lewis at the St. George's Hospital Vaccine Institute, where he used LT. He used a modified LT, a non-toxic LT, as an adjuvant with 2 different new vaccines. But he also had some people who were controls and got only the adjuvant. And on the left, you see one of his volunteers who got vaccine and this modified LT called LTK63 was non-toxic. And he got a Bell's palsy. It occurs about 30 days after the vaccination and is self-limited. But on the your left, my right, you'll see that there is a woman who got only the adjuvant, and she also developed Bell's palsy. And what this, the explanation for this, I don't have a pointer, but you see the nerves going, the facial nerves. LT and CT, they attach to gangliosides, in particular GM1 ganglioside, which is a major component of nerve sheaths. Neurophysiologists follow nerves by injecting LT or CT that's tagged. And the LT then goes centripetally toward the brain. And when it comes, you see where all those colors come together. There are 2 little passages in the skull that are very, very narrow. And when the serum antibodies occur to the antitoxin about 30 days after the immunization, in that there's a tiny little bit of inflammation, and in that narrow area, there's pressure on the nerve, and that is an explanation for everything that happens. I'm going to stop at that point, and thank you for your attention.
Thank you, Dr. Levine. Our next presenter is Dr. David Fernandez-Rivas from Massachusetts Institute of Technology. Dr. Fernandez-Rivas, your slides are up. You have the floor.
All right. Well, thank you very much. So can you hear me and see me, hopefully?
Yes, we see you and you're loud and clear.
All right. Well, thanks for this opportunity to tell you a bit of what we are doing in collaboration with the University of Twente and MIT. My name is David, and I'm going to talk about activities that receive funding from the European Research Council and the Dutch Research Council. So if we can move to the next slide, what I'm very happy is that Dr. Levin just introduced some of the ideas that I will just update of what is going on right now. So we have been hearing a lot about the fear of needles, and this is compounded with trust in institutions, the vaccine effects that we just saw. And there are some estimates that every person will receive on average 165 injections in a lifetime. And in adults, it's known that about 1 in every 4 people is afraid or have some sort of phobia for sharps. And in young adults and even children, this number is higher. So I'm trying to remove some of these problems as we will see in the upcoming slide. Please change. There's a logistic and environmental challenge that most people are not aware of. And every time we use a syringe and a needle, this has already been processed, sterilized, transported to the place where they are being used. And then after we use them, they need to be disposed properly. So we cannot just throw them into the environment. So it's estimated that, well, every year we are using 16 billion needle-based injections, and that was before the pandemics. And it's known that unsafe injections, so when people reuse the needles, mostly in developing areas, you have, people who die from infectious diseases. And, well, there are direct medical costs associated to this. So one of my dreams is to reduce this amount of waste. And then if we move to the next slide, please. One of the ideas I'm trying to propose is not entirely new, as it was presented before, and I will highlight in a few slides. If we remove the needle, we might remove a big chunk of the problem that many patients face. And if we then try to focus on superficial skin layers, we might have the advantage of inducing the same immune response with less volume than with the conventional, for example, intramuscular injections. Now, if we combine these two, people will be more interested in getting vaccinated, then we could be solving big problems. So one of the main challenges that I will highlight in a moment is that, well, injecting intradermally is quite challenging. Nurses or doctors need special training to really target properly these more superficial layers. And this is one of the engineering challenges that I'm facing nowadays. Please, next slide. So if we reduce the number of needles and all the materials, you also have to think about the metal part, the glue that is attaching to the base of the needle, and then the syringe. Then we have less or a smaller footprint for the whole vaccination campaigns. And we can also have less risk for prick incidents, which is very known in the medical world. So if we can remove the handling of this sharp object while providing a vaccination, we have an even more interesting advantage. Next slide, please. Now, there are some alternatives to the traditional needle, and I'm showing you here 4, and I think some of the speakers after me will be talking about microneedles. And Professor Levin was just mentioning about the jet injectors, or the traditional large volume injectors. I've been micro jet injector, and I will highlight what I mean with that. And less known but equally interesting, there are studies demonstrating that with a tattoo device you can have a better immunization response, because you can distribute the dose over a larger area superficially into the skin where the Langerhans cells are present, and, well, this has many clinical advantages. Next slide, please. Now, what we are proposing is not entirely new. And so if you can play the animation, you will see that there is, we are using a laser to hit a liquid, which could be the medicine. And due to the increased temperature, there's a bubble that grows at a fast velocity and pushes the liquid at a speed high enough to, in principle, penetrate the skin. But as we just heard, we could also use this to inject into the mucosa and other areas. I will have a slide in a few moments to illustrate this. So please, next slide. Now, I'm showing you now a real experiment in a moment, and you can see in the top left side one of the microfluidic device which we are fabricating and optimizing with a red dye for ease of visualization. And to the right, you see, in this case, a skin surrogate. And now when we play the video under, I want you to focus on the time scale. So the whole injection, this needle-free injection with a microjet, takes less than 1 millisecond. And in this case, you will see the jet penetrating into a translucent hydrogel that we use in the early stages of our test to demonstrate the penetrating capacity of these jets. There are some challenges there that we are addressing from the engineering part, but as we move in the next slide, please. What I'm trying to highlight here is that indeed, the jet injection idea is quite old. Already in the 19th century, in France, the whole dream started. And then in the late 90s and early 2000s, the World Health Organization banned the use of these multi-use nozzles. And then in the last few years, I'm shading a bit the medium range of this plot. New technologies like the mechanical or the spring-loaded, there was an example from Professor Lavin. And what we are focusing is a new type of laser, which is continuous wave lasers using diode components that are cheaper, portable, and safer than the traditional pulse laser technology that has been used in the past. Next slide, please. Now, then I'm also trying to change the way that people look at needle-free injection, because in the past, most scientists and doctors have been focusing injecting deeper in the skin. So you can see the X bar at the bottom of the graphic. And typically you need to inject large volumes in the order of 0.3 milliliters or more. So that's the Y-axis. But if you click once more, I have a small text, please. I'm focusing on this more superficial and small volume delivery because then I see more opportunities. And this is what we've been exploring in the last few years. And I want to show you some of the progress we've made. Please, next slide. So the microjets offer different advantages over the traditional or still pioneering concepts such as microneedles and older jet injectors, because it causes no damage so far that we have measured to ex vivo samples. We have better control on the volume that we can inject. Also, the penetration control, even though it's shallower than the jet injectors and the tattoo machines and some microneedles, but this we are now doing tests to have some sort of comparative analysis, and we think that we can prepare this technology to produce less waste. Well, the cost is something that with economy of scale we can improve in the future. Please, next slide. Now, the early or the first areas that we're trying to test this technology is where we can use liquids that don't have any therapeutic effect, such as medical tattooing. For example, patients that have received a mastectomy, you can redraw the nipple, and you can also camouflage different wounds. But then if you click once more, please, the same concept we have been testing with insulin, and the whole process doesn't affect the insulin composition. We are now doing some tests trying to inject in the eye and allergy tests. And well, in the future, of course, cosmetics applications could be desirable. Next slide, please. So we have published some evidence that this microjet injector has the potential to well, compete with the existing microneedles and other delivery methods. So, well, I'm giving you all the references here that you can check later on. So if you can move to the next slide, please. Yeah, next. So when we compare ex vivo studies and we use the tattoo needles, we see damaging or wounds into the skin. But when we do the same cross-section analysis, we see that we are able to penetrate the stratum corneum for a few hundreds of micrometers, which initially I thought it was quite modest, but in conversations with endocrinologists and dermatologists, they were already very excited to see that with not using optimizations and early stage research, we were able to do this. So next slide. Now that the main question we're trying to answer from an experimental point of view is to explain how it's possible that we manage to make these molecules get so deep without making a hole, because we cannot see any hole, which means it's so small that it will heal very fast, or maybe the liquid manages to percolate in between the cells. Next slide, please. So what we're doing right now, we incorporated a spin-off company with the University of Twente, and we are trying now to raise funding to increase the technology readiness level of our technology and try to team up with companies, international players. Some of them I cannot disclose due to NDA agreements. And well, I'm interested in hearing from any of you in the audience if you have ideas to collaborate. And in the future, I'm interested in having like a handheld device that could be used in that way. Next slide. I think we are nearing the end. So this we can skip in aim of the time. This is more like the blur from the company. We have a technical team with 4 PhD students, and the next slide I think is even more interesting for you to see that we are getting feedback from world experts in different fields. And well, I'm also open for collaboration with any of you. Next slide. I think then this is my last slide. Before I thank you, I believe that my role as professor at the university, I'm already educating the even younger generations that are coming to the university. So you see one of my PhD students already assisting me on a museum where we are already trying to explain the limitations and the advantages of this technology. And I think we need to educate all stakeholders in society to, well, make this idea go further. Thank you very much for your time.
Thank you, Dr. Fernandez-Rivas. Our next presentation is going to be presented by Dr. Xiaomin Tian for his team on vaccine delivery by 3D printed microarray patches. Dr. Tian, your slides are up and you have the floor.
So thank you. Julian will start.
Yeah, so thank you. Like Xiaomin just said, I'm Jillian Perry, and Xiaomin and I are going to split this presentation on vaccine delivery using 3D printed microarray patches. Next slide, please. All right, so I first wanted to give a broad overview about microarray patches, what they are, and the different materials they're made out of. So first off, microarray patches are patches that carry arrays of microneedles that have projections on them that range in sizes from 100 to 100 or 1,000 microns in length. These can be made out of many different materials, ranging from metals to polymers. There's many types of maps in the literature and on the market: solid maps, solid coated, hollow maps, as well as dissolvable maps. And the ways in which they're manufactured are different. There's laser cutting or different etching techniques, photolithography, micromolding, and as we will touch on later, 3D printing. So the reason we're interested in maps for vaccine delivery has already been touched on, but basically they can deliver through that stratum corneum to deliver drugs or vaccine cargoes into the skin. Because the skin is lacking nerves, it's considered a painless application, and there's a potential for them to be self-administered. Furthermore, for specifically solid-coated microneedle applications, these dry formulations have the potential to be thermally stable and therefore can eliminate the need for cold chain distribution and storage. Next slide, please. Again, this has been touched on, but why we're interested in skin vaccination is mainly due to the large number of immune cells that are present in the dermal space as compared to the traditional vaccination route into the muscle. So if you see this cartoon here depicting the number of immune cells present in this dermal space versus the muscle, you can clearly see that. And this leads to the potential for dose sparing. And as I'll already mention, the lack of nerves in this area makes this for a pain-free vaccination site. Next slide, please. Thank you. So this is briefly just to give you some history of the formulation of MAPS and where we are today. So as you can see, in 1976 was the first patent for MAPS, but it wasn't until the late 1990s that we see the first examples in the literature of solid MAPS made out of silicon using microfabrication techniques, and we're calling these Generation 1 MAPS. Followed on in the 2000s were hollow maps, again using these same microfabrication techniques to manufacture them. Generation 2 microneedles using molding lithographic techniques came in the early 2000s, and this yielded polymeric molded microneedles. They could be either solid or hollow. And quickly after the publications for this were released was the invention of these dissolvable maps, so in which the needle projections actually would dissolve off in the skin, leaving less to be thrown away. In 2010, we see the first clinical trials using micron jet, which is actually metal hollow maps to deliver the influenza vaccine, and then quickly followed on with that using the same technology to deliver the polio vaccine. In 2015, we can see that these dissolvable maps were used to deliver influenza vaccines. And in 2016, our group published a paper in which Generation 3 microneedles were shown, which is using additive manufacturing, specifically our 3D printer, to directly fabricate complex geometry maps. And in 2021, we recently showed that we could use these 3D printed maps for vaccine delivery in animals. In 2021, we see another vaccine trial using these dissolvable maps, and here we are in 2022, and there are clinical trials ongoing to deliver these COVID-19 mRNA vaccines. So here is where I'm going to pass it over to my colleague, Xiaomin. Next slide, please.
So this slides basically give you an overview of the clip technology we have used to fabricate 3D printed map products. So this clip technology was created like around 2014 and published in Science 2015. So basically, this is like other digital light fabrication process. The printers actually create microneedles from a UV curable resin. What's unique about the system is a specialized window, is oxygen permeable window at the interface of resin and the light projector. This created a data zone which separate the printed objects from the window, therefore eliminating the delaminating process, and affords a very fast printing speed. In addition to that, the clip technology also offered advantage of precise control of geometry and the needle matrix. On the right side, you can see that we have used a 20 micron resolution prototype printers to fabricate a solid maps with different types of needle geometry. And it was also fabricated from biocompatible materials and dissolvable materials that can facilitate fast skin delivery and cargo dissolution. And recently, the Simon team at Stanford actually established 1.5 micron resolution printer. This high resolution printer actually enables exploration on some very unique lattice microneedle structures. And also, versatility also shows on the patch level integration. This here is an example that you can preform antigen array and adjuvant array and combine them. You can also combine like different types of vaccine, dry vaccine formulation, the patches, and combine them at the site of application. Next slide, please. So with this powerful tool, we are trying to address the current unmet patch delivery. So, for example, to make the patch delivery more cost-effective and to improve the skin insertion, skin retention, and the removal, and also make a rapid cargo delivery available. And we also spend effort in improving the dry formulation and thermal stability of vaccine, therefore extending the shelf life of vaccines. So our early work focused on the solid microneedles. We published this last year in PNAS. We have demonstrated that on the solid microneedles, you can increase the cargo payload by adding more surface area. As shown here, that we have used faceted microneedles with increased surface area and payload. And in animals, we have shown that by using the solid needle delivery, we can not only induce 50 times higher antibody responses than a needle syringe injection under skin, and also we can induce a broader IgG subclasses population. Here we'll also demonstrate that the dose-sparing effect with the patch delivery. That means, okay, you can elicit similar level of immunity with the less antigen or adjuvants. Next slide, please. Okay, with the invention of high resolution of a 3D printer, we can incorporate a lot of unique features into the single needle designs. Here on the left side, we're showing the lattice microneedles in the CAT design, also in the SDME images. So currently, there are DeSimone team are generating 200 plus different designs and try to screen from them needle designs that actually can optimize for the cargo payload and also skin insertion strength. So here we show that we can not only deliver solid state foam, use these lattice microneedles, and also deliver the liquid formulation that easily entrapped in the needle space. On the right side is fabulous dynamic design elements that can only be enabled by high-resolution 3D printing. Shown here are some living hinges incorporated in individual needles. So you can show these hinges can be retractable, and while insertion into the skin, they expand, therefore increase the skin tension and retention the whole patch in the skin. And they can also retract at removal, make it removal easy. So it's very useful design, optimize cargo delivery and also healthcare monitoring of through interstitial fluid sampling. Next slide, please. So regarding mat-based vaccination, we still see challenges. So one is to formulate more effective and safe vaccine patches and affordable for various different vaccine types. So our current focus is on the protein and protein nanoparticle-based subunit vaccine and for SARS-CoV-2 and dengue vaccines. One big effort is also to enable patch delivery of RNA vaccines that a lipid or polymeric nanoparticle based vaccines. Upcoming effort also involves whole virus-based live attenuated vaccine efforts. Hopefully, we can by these works, we can demonstrate the potential and capability of using 3D printed maps for vaccine delivery. Another challenge is the rapid integration and scale of manufacturing. So DeSimone team actually is working on a high throughput platform to streamline the continuous production of patches. So our anticipation is that a biofactory or biofoundry equipped with 250 printers can rapidly produce 100 million doses of pre-validated vaccines in 3 months of time. So that sounds very promising and doable to us. And so next slide, please. So finally, I want to thank multiple teams at Stanford and UNC Chapel Hill and our industrial collaborators and our funding agencies. And please send us your questions about microneedle delivery. Thank you.
Thank you, Dr. Chan and your team. Our next presenter, our final presenter for this panel is Dr. Daryl Irvin from the Massachusetts Institute of Technology. Dr. Irvin, your slides are up and you have the floor.
Thank you. I'm going to talk about mucosal immunization, focusing in particular on intranasal and respiratory delivery. Next slide, please. So Dr. Levine already introduced the idea of immunizing through the nasal passages or the airways. And here the goal is to deliver vaccine to the nasal-associated lymphoid tissue, like that includes the tonsils. And one of the reasons for this is to drive local immunity. Next, please. Stimulating immune responses at these sites in the local mucosal tissue can cause, for example, the production of antibodies like IgG and IgA that are specially equipped to protect mucosal surfaces and elicit strong immune responses in the mucus layers in the nasal passages and in the airways of the lungs, which would be of interest for respiratory pathogens such as SARS-CoV-2, RSV, and influenza. Next. The main challenge with immunizing through the airways is that the airways are designed to keep things out. There's a layer of mucus that is designed to quickly clear material and microbes, and an epithelial barrier that's lies between the external airway surface and the underlying nasal-associated lymphoid tissue, where T cells and B cells and other immune cells live in these airway adjacent nasal-associated tissues. So the challenge is, how do we get vaccines across there? And currently, the only licensed nasal vaccines are based on live attenuated replicating pathogens. So we'd like to be able to do this with non-living vaccines, such as simple protein vaccines. Next slide. Oh, and this graphic has been messed up a bit. I'll try and describe what this should be showing, which is that there's an interesting piece of biology in the nasal passages and the airways, which is based on the trafficking of albumin and antibodies. So there's a lot of albumin and antibodies in the mucus layer, and the way that material gets there is through a process of transcytosis, where on the basolateral surface under the airway, antibodies or albumin are taken up by the epithelial cells, and they bind in endosomes to the neonatal Fc receptor, which transports them across the cell and releases them into the mucus layer. And this, interestingly, is a bidirectional transport. So antibody and albumin is constantly moving out and back into across the epithelial barrier through this process. Next slide, please. So given that biology, we proposed or hypothesized that one might be able to get vaccines delivered across the epithelial barrier in the airways by using albumin as a molecular chaperone. And the way we approach this is shown on the left here, where we take a protein antigen of interest and we chemically link it to a lipid tail that's designed for binding to albumin. And as shown in the cartoon in the top middle, one of albumin's main functions in vivo is to serve as a fatty acid transporter. It has 7 different lipid binding pockets. And so we designed these molecules we call amphiphile vaccines or AMP vaccines to associate with albumin by virtue of this short polymer spacer shown in blue that links the protein to an albumin binding lipid, with the idea being that on administration, this amphiphile molecule would bind to albumin that's already present in the mucosal surface and thereby get transported wherever albumin goes. And here, of course, we're hoping it would go with albumin across the epithelial barrier. Next slide, please. So here the idea is that we would administer, for example, through a nasal spray, these amphiphile immunogens into the nasal passages. They would bind to albumin in the mucus and then traffic with albumin through the mucus and through this transcytosis pathway into the underlying nasal associated lymphoid tissue. Next slide. So we've reduced this to practice with a couple of different antigens in animal models. I'll show you some data on SARS-CoV-2 antigens and also some HIV antigens. For SARS-CoV-2, we focused on the receptor binding domain, or the RBD, that's shown here in orange on this crystal structure of the envelope spike of SARS-CoV-2. And we basically chemically, site-specifically link our amphiphile tail onto that RBD domain at the N or C terminus, making our amphiphile vaccine molecule. Next slide. And the first thing we looked at is in mouse models where these antigens go if we administer a free protein or this amphiphile molecule. And what we're looking at here is a cross-section through the nose of a mouse. And you see this curved structure, which is the bone and the epithelial tissue. In the left side, the free antigen is labeled here fluorescently in a red color. And what we see is that the antigen is all lying at the middle of this airway passage labeled M, which is basically the top of the mucus layer. And the top of the epithelial barrier is below the mucus at the point labeled E. And you can see that very little of the antigen in red is actually getting to the epithelial surface. It's all trapped in the mucus. But if we instead administer the same amount of this protein linked to this albumin binding tail, now we see all of the protein relocalized to the surface of the epithelium, which is where we need it to get to for it to transport into the nasal tissue. Next slide, please. And if we look at 24 hours after administration into the airways, looking now at higher resolution, to look at where the antigen gets to, what we find is if we administer our AMP vaccine, shown on the left here in red again, where the epithelial barrier is highlighted by this blue nuclear stain, you see the row of nuclei of the epithelial cells, and you can see a lot of the antigen is on the top layer of the epithelium, but then we can also see material underneath that epithelial barrier that's been transported through. And if you look on the right image, in an animal that's genetically deficient in the neonatal Fc receptor, that amphiphile vaccine is all stuck on the top of the epithelium and that transport is blocked. So we really need that transport pathway to get into the tissue. And you see in the middle image that if we had the free antigen without this albumin binding domain, it's completely cleared away at this time point, and none of it's gotten through. Next slide. So once the antigen gets transported through the tissue, there's another useful property of these amphiphile molecules, which is the lipid tails are also happy to insert into cell membranes, and that helps the vaccine stay in the nasal lymphoid tissue once it gets through the epithelial barrier. Next. And we can see if we measure the amount of vaccine that's in the nasal tissue over time, when we have this amphiphile form of it that has this cell membrane inserting property, it sticks around for several days, whereas the free protein is again getting quickly cleared away. So we have these two effects of getting transported across the epithelial barrier, and then it stays in the lymphoid tissue for a prolonged period. Next slide. And so I'll show you some immunization data first in mice. This is using the SARS-CoV-2 vaccine, where we give 2 shots at time 0 and 4 weeks later. Next. First, looking at antibodies in the blood, IgG and IgA, we see that compared to the free protein given intranasally in red, the amphiphile vaccine in blue gives much, much higher antibody levels in the systemic circulation, so good systemic immunity. Next. But in addition, what really gets us excited is there's a strong mucosal response in the nasal passages, in the bronchiolar lavage, so deeper in the lungs, that's the BAL, in the saliva, and in mice, we also see even distal mucosal immunity, so antibody in the vaginal mucosa and the fecal matter. So in mice, a very strong response for both IgG and IgA. Next slide, please. When we measure neutralizing antibodies against SARS-CoV-2, mirroring the antibody ELISA titers, there's very high neutralizing activity in the serum, and also, excitingly, in the nasal wash and in the lung tissue, which we think is one of the real advantages of this immunization approach. Next slide. As many vaccine technologies that work in rodents don't translate well to large animals or humans, we've also tried to test this technology in non-human primates. And in a pilot study, we administered fluorescent vaccine into the nasal passages of macaques. And as in mice, we just measured how much vaccine got taken up into the nasal-associated lymphoid tissue. And in macaques, we saw, as we saw in mice, that there was a great increase in the amount of vaccine going into the lymphoid tissue, shown here in blue. Next slide. And then similar to what we did in mice, we gave repeated immunizations intranasally with either, this is now with an HIV immunogen, either free protein antigen or amphiphile antigen. And here we've measured the antibody levels in the blood over time. The red arrow is showing the dates that the animals were immunized. And importantly here, I want to draw your attention to the serum IgG levels, where after a single immunization between week 0 and week 8, there's strong induction of systemic antibody in the animals that got the amphiphile vaccine, whereas none of the animals are seroconverting when they get the free protein until they get boosted. And then on the right, you see that we got not only IgG, but also IgA that's implicated in enhanced protection at mucosal surfaces. Next slide. And then finally, as we'd hoped, we also saw enhanced IgG and IgA responses in the nasal passages of these animals. So the amphiphile immunization being shown in blue and the soluble protein in red. So we think this could be really attractive, for example, for SARS-CoV-2 as a way to give us frontline protection that might allow, for example, vaccines to do a better job of actually blocking infection rather than mitigating symptoms. Next slide. So just to summarize, what I tried to show you is this simple idea of using albumin as a molecular chaperone by designing vaccine antigens that can bind to albumin that's present in the airway and then follow this transcytosis pathway into the underlying nasal tissue where it can be retained through this lipid tail to drive strong local humoral immunity and potentially T-cell responses as well, though we have looked at that much less so far. Next slide. So I'll just stop there and acknowledge this. What I've shown you is all the work of a terrific postdoc, Brittany Hartwell, who's now starting her own lab at the University of Minnesota, and we're grateful for support from the NIH, the Gates Foundation, and the Reagan Institute on this work.
Thank you, Dr. Irvine, and I want to thank the other members of this panel. Very interesting advances to getting away from our friend the needle. We have run long on time, so we're not going to take verbal questions or comments. If you have questions or comments, if you would please email those to Ann or I, and we'll make sure to get those to the presenters. We have reached the end of our first day of our NVAC meeting. I understand we do not have any public comments on the line. So I want to thank you for attending the first day of our June 2022, our first hybrid NVAC meeting. I hope you all have a good evening, and we'll look forward to seeing you all bright and early tomorrow morning at 9 o'clock Eastern Daylight Time.
Produced by the U.S. Department of Health and Human Services.